Hello, everyone. Today's presentation is about cervical spine trauma. Let's start by having a general overview of some important figures. 3% of all motor vehicle accidents patients have major cervical injuries. This percentage is even higher among patients who have head injury because it constitutes approximately 15%. Now, 15% of cervical injuries are missed or delayed in diagnosis, and this has a significant impact on permanent neurological deficit, which may reach up to 30%. Injuries in the cervical spine mostly occur at the two ends, either at the craniocervical junction, approximately 30% of cases, or in the lower cervical spine, and that's almost 50% of the cases. And this is because at these two levels, or the top and the bottom parts of the cervical spine, is where most of the cervical mobility occurs. Now, clinically, ER physicians may rule out cervical spine injury without the need of doing any plain radiographs, particularly if there's no loss of consciousness or altered mental status, and the patient can verify clearly that there are no pain. The patient has full voluntarily performing full range of movement for the head and neck, no focal tenderness or pain, no neurological deficit in these cases, using the Nexus criteria, almost 100% native predictive value, and the neck collar could be removed without the need of doing any plain radiographs. However, if any of these factors is missing, meaning the patient had altered mental status, or the patient is complaining of neck pain or rigidity, or the range of movement is not full and free, or if there's any neurological deficit, then cervical spine screening plain radiographs is warranted. The screening protocol is composed of a lateral, an AP view of the views of the cervical spine, and an odontoid view or an open mouth view, making sure that the full extent of the cervical spine is visualized from the skull base down to the cervicothoracic junction, and that the odontoid view clearly visualizes the body of C2, the odontoid process, and the lateral masses of C1. One of the most common pitfalls that happens and result in catastrophic outcomes is that the study is incomplete, the craniocervical junction is not included, or the skull base is not included, and then a fracture is being missed at that level, only to recognize this later on after the patient has been in the hospital for a few days and neurological deficit is progressing. It is important to view the three, and some people add a fourth line, on the sagittal view, on the lateral view of the cervical spine, the anterior and the posterior vertebral body lines, which correspond to the anterior and posterior longitudinal ligaments, because these actually maintain the alignment and preserve the integrity of the anterior column of the cervical spine. The third line is the spinolaminar line, which is the junction between the spinous process and the lamina. Similarly, it's important to assess the prevertebral soft tissue and its thickness. I don't believe in memorizing numbers. These are only for your reference. However, above the level of C5, it is important to identify that the prevertebral soft tissue thickness is not more than half of the anterior-posterior dimension of the corresponding vertebral body. Below the level of C5, and this is because the esophagus starts at C5, then the thickness should not be more than 1 full AP diameter of the corresponding vertebral body. In the pediatric population, there are certain concerns and pitfalls that we should be aware of. Number one, it is rarely to obtain a plain radiograph without the child crying, and with deep inspiration, expiration, you may get accentuation or exaggeration of the thickness of the prevertebral soft tissue thickness. The other thing is, because of the laxity of the ligaments in this age, then a pseudo subluxation in the upper cervical spine might be observed. Going back to the complete visualization of the vertebrae, notice that in this lateral view, we have down to C7. However, T1 is not visualized. This is an incomplete study. This is an inadequate study. In order to visualize the thoracolumbar, the cervico-thoracic junction, we might need to put the patient in what is known as swimmer's position, where one arm is being placed above the level of the head, while the other arm is being pulled downward towards the knee, and the radiograph is being taken through an axillary approach, trans-axillary approach. This gives you this image showing the humerus, the ipsilateral humerus, being pushed out of the field towards above the head, and the cervical thoracic junction is clearly visualized. And as it shows in here, there is a complete anterior translation of C7 on T1, which is a significant flexion injury. We will come to this later on. So swimmer view is an important view to remember to visualize the cervicothoracic junction. Placement of the arm above the head should be voluntarily, should not be forced on the patient, particularly in the setting of trauma. Now, what if no fractures could be identified, however, the patient persists complaining of pain? Well, this may indicate pure soft tissue injury, and this can be verified with extension and flexion views. Again, flexion extension views or any other neck movement, even rotational movement, should be done by the patient himself or herself actively, voluntarily, should not be performed or forced by the treating physician or the technologist on the patient. This is the flexion extension view, and that's a normal examination. We have to look for the integrity of the 3 or 4 lines that we have discussed before. And we have to assess the prevertebral soft tissue thickness. Another case, and in this case, if you look clearly and carefully, you can see the odontoid process or the dents of C2, and this is the anterior arch of C1. And it's important to identify the distance between the two. As you put the patient in flexion view, the distance is significantly increased. I'll show you this in magnification. This is the magnified, this is the extension, and this is the flexion views. And notice the predental space, or the space between the odontoid process, the anterior cortex of the odontoid process, and the posterior cortex of the anterior arch of C1. It's usually 2 to 4 millimeters, and how significantly widened it is in the flexion view, which indicates disruption of the transverse ligament that hugs or connects the odontoid process to the back of the posterior arch of C1 and stabilize the junction. This is very important and could be life-threatening. It is an unstable fracture and should be further evaluated with CT scan. So again, the first line is to check the adequacy of the field, meaning covering from skull base down to the thoracic inlet. and then the intactness of the alignment with the anterior and posterior vertebral lines, with the spinolaminar line, and with the interspinous or spinous processus line. They do not have to be straight. They may be straight because of cervical spasm, or could have mild lordotic curvature. However, what's important is that there is no step deformity or offline displacement at any of these lines. Once these are checked and they are intact and the patient has no persistence of pain or tenderness and has a good range of movement, then one may remove the neck collar. Otherwise, the neck collar should remain on. As we are assessing the alignment, it is very important to look at the craniocervical junction. The tip of the clivus, which is known as the basion, is usually pointing towards the tip of the odontoid process, with the distance between the two not exceeding 12 millimeters. This is known as the Harris measurement. Similar, however, less significant measurement is the distance between the top of the posterior arch of C1 and the tip of the occipital bone, which is known as the opisthosome. Usually is also 12 millimeters. However, it is more difficult to visualize on plane radiographs. Now, power ratio refers to the intersection of two lines. The first line is connecting the basion, which is the tip of the clivus, to the anterior cortex of the posterior arch of C1, while the other is the opisthosome, which is the tip of the occipital bone, to the posterior arch of the posterior cortex of the anterior arch of C1. So these two lines cross each other, and the ratio should not be greater than 1. It's usually in the range of 0.8 millimeters. An abnormal increased ratio is indicative of craniocervical dissociation. After we check the alignment of the cervical spine and the craniocervical junction, we move on and we check the vertebral bodies. And you can trace the outline of the vertebral bodies. All the vertebral bodies are almost square in nature, in appearance, with the exception of C2, which is rather taller and has an odontoid process attached to it. These rectangular shapes vary in height, and they're usually smaller at C4 and C5, with slight decrease in the anterior vertebral height in relation to the posterior vertebral height. Otherwise, they are well maintained. The next step is to evaluate the spinous processes, the laminae, the facet joints, and the pedicles for any sign of malalignment or disruption. Assessment of the intervertebral discs is also important, as they constitute a major part of the soft tissue components of the cervical spine. Assessing them is looking for any evidence of abnormal narrowing of the anterior or the posterior parts of the intervertebral discs, or any sign of any associated thickening of the prevertebral soft tissue. Degenerative changes may occur with in patients above the age of 50, which may result in reduction of the vertical height of the intervertebral discs. However, this is usually in the lower cervical spine, with other evidence of degenerative changes such as end-plate sclerosis and osteophyte formation. Again, assessment of the prevertebral soft tissue is important. These are rough numbers. They should not be applied to adherently. However, these are guidelines that one can use to assess the evidence or the presence of prevertebral soft tissue thickening, which is a sign of the presence of hematoma in case of cervical spine injury and motor vehicle accidents, major trauma, or could be a sign of abscess formation, particularly in the nasopharyngeal and retropharyngeal spaces in cases of infection. The anteroposterior view is also important to assess. However, it has limited value, primarily assessing the alignment of the vertebral bodies by drawing line that connects the articular pillars of the vertebrae and that they are in one alignment. Also connecting the spinous processes and make sure that they are in one alignment. Malalignment of the spinous processes could be due to trauma or rotation. However, it could be due to head tilt during examination. The intervertebral disc spaces and the heights of the vertebrae should also be assessed. Finally, the facet joints of Luschka, the lateral facet joints, are also assessed for any abnormal narrowing or malalignment. Looking at the odontoid view or the open mouth view, it is very important to make sure that we include the body of C2 and the odontoid process in its entirety, the lateral masses of C1, and the corresponding occipital condyles. You've got the occipital condyles resting on the superior articular surfaces of the lateral masses of C1, and the articulation between the lateral masses of C1 and the body of C2. The odontoid process or the dents and the lateral dental spaces, which are between the dents and the lateral masses of C1 on either side. The uneven measurement here is most likely due to a rotation during the examination itself, but it may indicate injury or trauma, or even more importantly, fractures in the right clinical setting. Now, the outer border of the lateral mass of C1 should line up with the outer border of the body of C2 to make sure that there's no evidence of burst fracture of C1. So this is how the odontoid process. There are some artifacts like the sclerotic line in here and the sclerotic line in here and the lucent line in here, and these are all over projection lines from the anterior and the posterior arches of C1, as well as from the air spaces in between the incisors, and should not be mistaken for any abnormalities. Neurosurgeons classify stability into or assess stability by looking at the cervical spine in form of columns. The anterior column is formed of the vertebral bodies, the intervertebral discs, and the anterior and posterior longitudinal ligaments, while the posterior column is composed of the pedicles, the laminae, the spinous processes, the facet joints, and the corresponding ligaments. In order to have an unstable fracture, both columns should be involved. The intactness of a column is usually indicative of stable injury. So, now we're going to talk about how do we classify, approach cervical spine fractures. The mechanism in general is either due to a hyperflexion or a hyperextension or a vertical loading injury. In hyperflexion, there's excessive flexion, which results in tear of the posterior ligaments, primarily the interspinous ligament, rendering the posterior element rather unstable. It may or may not be associated with wedge fractures or a teardrop fracture. It may or may not be associated with facet dislocation. In comparison, the hyperextension is associated with tear of the anterior longitudinal ligament, and it may be associated with a teardrop fracture of a tug or a pull fracture kind of mechanism. It may be associated with Hangman or an odontoid fracture. We come to these. Vertical loading results in compression fracture, which has a unique status where it is affecting C1, and it is known as Jefferson fracture. So, in the Atlanto-occipital assessment, there is a major identity, which is the Atlanto-occipital dissociation, meaning the anterior displacement of the occipital condyles in relation to the superior articular surface of the lateral mass of C1. The occipital condyle should be resting on top of the lateral mass of C1. Anterior displacement of the occipital condyle, as it is shown in here, and as it's shown here on the CT and clearly shown here on MRI, meaning that the whole cranium has moved anteriorly in relation to the cervical spine. This stretches the brain stem and causes almost immediate death. Because also with this, you get disruption of the power ratio and the Harrison measurement, with formation of large intraspinal hematoma and maybe even prevertebral soft tissue swelling and hematoma. The flexion injury affecting the cervical spine could be purely soft tissue, where you have disruption of the interspinous ligaments with no associated fracture. Maybe there is some bone marrow edema, but the presence of edema does not necessarily mean that there is a fracture. However, with excessive force, you get wedge teardrop fracture, which may affect any of the upper cervical or lower cervical levels, but primarily C2 and C3. In this situation, you've got C4 fracture with anterior wedging, loss of its integrity, the cortical buckling, loss of the normal rectangular shape, often associated with posterior displacement of the vertebra and compromise of the spinal canal. This may result into spinal canal contusion. This is an unstable fracture. Another example of a wedge flexion injury, where actually you can see that this is C5, has lost its normal configuration, has lost its anterior vertebral part because of excessive flexion. It's completely collapsed, and this is the teardrop fracture. CT scan also visualizes another fracture affecting its the posterior cortex of the vertebra above. Notice the narrowing of the spinal canal at the level of the fracture because of the retropulsion of the posterior fragment, compromising the spinal canal, compressing and compromising the spinal cord. The signal intensity of the spinal cord is important to assess because the presence of edema by itself is recoverable. However, the presence of hemorrhage, which is the dark signal within the cord indicative of a poor long-term outcome. It is a comminuted fracture with multiple fragments and minimal displacement. You can see the vertical and the comminuted splits of the teardrop fracture of C5, secondary to extensive flexion injury. However, not every case is straightforward. So how about this case? If you look carefully, I mean, you can pause the video for a minute and look at this before going to the next slide. Sort of an eye sharpener test. However, for sake of time, we will proceed, and you can see that there are multiple findings. There are multiple chip fractures. There is narrowing of the intervertebral disc space, and there's widening of the interspinous space. So this is a flexion injury with disruption of the posterior ligaments, with disruption of the intervertebral disc associated with chip fractures coming out of the facet joints in here. Obviously, when you look at the soft tissue, you see also there's evidence of intraspinal hematoma. And when you look at the MRI, you see the disruption of the disc with the hematoma within the disc, This is a ruptured disc associated with the hematoma and the compressed and contused spinal cord with intraspinal edema. What might be missed, obviously there's a large hematoma in the paraspinal muscles and the disruption of the interspinous ligament. However, what could be missed in a long night on call are other subtle findings, such as the abnormal signal intensity in the vertebral artery, indicative of thrombosis, and the abnormal signal intensity in the posterior column of the spinal cord, indicative of spinal infarction, as confirmed with the vertebral artery thrombosis in here. The next category is the facet dislocation. Facet subluxation and dislocation is a continuum. Usually, the facet of the vertebra above, the inferior articular surface of the facet of the vertebra above, covers completely the superior articular surface of the vertebra below. With excessive flexion injury, the facet of the vertebra above will start sliding anteriorly, uncovering the surface or the articular surface of the vertebra below. So there will be mild uncovering, complete uncovering, and eventually falling down and interlocking. So this is a stage of complete uncovering where the posterior edge of the articular surface of the facet above is pushed against the anterior edge of the articular surface of the facet below. Further flexion injury, the facet will fall in here anterior to the vertebra below and gets locked because it cannot go back to its location again without traction, and this is the complete locking. This surface or the inferior surface of the facet of the vertebra above, which was supposed to be here, has moved forward and then fell down, so now it is completely locked. So the vertebrae, the facet, the articular surfaces are completely naked. This is seen in the lateral view of the cervical spine as 25% up to 50% translation of the vertebra above on the vertebra below, with uncoverage of the facet associated with widening of the intervertebral of the interspinous space, indicative of ligamentous injury, and maybe associated with a chip fracture or soft tissue edema. Now, if it is unilateral, it will be associated with a rotational element, which will be seen on the AP view of the cervical spine as malalignment of the spinous processes. Look at the spinous processes in here that suddenly swings this way before it comes back to the center. So that's malalignment. And again, this is the uncoverage of the facet and the anterior translation, less than 50% anterior translation of the vertebra above to the vertebra below. Obviously, this will compromise the spinal canal and impinge on the spinal cord, resulting in cord edema and impingement. This is the facet that has locked. This facet is still intact. This has locked. Look at the rotational element, the orientation of the vertebra above in relation to the orientation of the vertebra below. So it has mal-rotated, unilateral facet lock. This is the usual appearance of the hamburger with the bun above and below. Now, if this is the bun above, then there's no bun below. The bun below has moved anteriorly. This is the reversed hamburger sign. The complete lock and uncoverage of the vertebra of the facet. This facet has slid anteriorly, uncovering this facet. Now, when it is bilateral, the translation is more than 50%. Complete loss of coverage, giving what is known as the bow tie appearance. This is one part of the bow tie, and this is the other part, and this is the knot in between. This is complete bilateral facet lock. With severe compromise to the spinal canal, you may imagine the spinal cord is running this way, then suddenly has to go this way and up. Complete compression and not uncommonly complete transection of the spinal cord at this level. This may be associated with fractures or maybe purely on the basis of soft tissue injury with complete disruption of the intervertebral disc and the interspinous ligaments. An example of bilateral facet lock, you can see that the superior articular facet that should be covering this facet has moved anteriorly, has perched, and then fell down, and now it is completely locked. This is one side. This is the other side, showing the deformity, the severe deformity of the spinal canal and the severe compression of the spinal cord. Again, the facet lock. Bilateral, reversed hamburger sign. Lots of paravertebral soft tissue edema and hematoma, large intraspinal hematoma, prevertebral soft tissue hematoma, and a bilateral facet lock. Treatment is by putting traction through a halo that is screwed to the skull with gradual buildup of weight in order to pull the vertebra that has fallen anteriorly, to pull it back upward and reverse it back into position. You want to unlock this facet. So you have to pull it up and then place it back. And you can see from falling down with gradual increase of weight. This is done by neurosurgery, obviously under some muscle relaxants and very close observation, and being pulled up and then being pushed till it's reversed. Once it is reversed back to its normal location, you have to fix it because this is an unstable fracture and all the ligaments are disrupted, so it has to be fixed with plates and screws. Spinal injury occur with these fractures. Obviously, you can see a different spectrum of spinal injury, from cord compression due to some vertebral fragments and disc fragments compressing the cord, deforming it, to a complete cord transection. As I said before, the presence of hemorrhage within the cord substance is associated with poor motor outcome, 8% recovery when there's hemorrhagic component versus 60% recovery when there's no hemorrhagic components. The last type of flexion or hyperflexion injury is the Clay-Shobler fracture, which is a pull fracture or a tug fracture from the tip of the spinous process due to sudden severe flexion injury or flexion movement. Shoblers, because it is often seen among hay shovelers. It is a stable fracture. It does not have any usually neurological deficit associated with it, and usually treated conservatively. Moving now to the hyperextension injury, which usually occurs in motor vehicle accidents with the dashboard injury, where actually the inflatable balloon or the windshield being hit by the chin of the passenger or the driver, throwing the head into a hyperextension sudden movement. The most common fracture that occurs with this scenario is Hangman fracture, which is basically fracture of the pars interarticularis. The pars interarticularis fracture may be just a hairline fracture with no displacement. This is type 1, and it stands for about 65% of cases. So this is the most common. It is unstable. However, it is not associated with any neurological deficit. Now, if the fracture is associated with anterior or posterior tilting of the odontoid process, or associated with facet lock, or associated with other types of fractures and ligamentous injury, then this is a type 2 fracture accompanied with disruption of the intervertebral disc. This is less common, however, and it is unstable. However, again, it is not associated with significant neurological deficit. The lack of neurological deficit in Hangman fracture is primarily because of the large diameter of the spinal canal and the decompression that occurs with the fracture itself. So the spinal canal is decompressed. Type 3, which is the least common, is basically same findings as type 2 in terms of the tilt and the displacement of the vertebral body with the disruption of the intervertebral disc. However, it is associated with a facet lock. The name hangman comes from the procedure in hanging criminals, where the rope is wrapped around the neck and the knot is being placed under the chin to maximize the extension force during the hanging procedure. So you can see here the fracture line associated with a chip fracture, and there's a large prevertebral soft tissue edema and hematoma. This is a classic type 1 Hangman fracture. The same example and another example showing the fracture itself, just seen in here, the pars interarticularis. You can see it on CT scan going through the pars interarticularis bilaterally. You can see it through one pars and the second pars in here. So this is the classic Hangman fracture. Notice how big is the spinal canal, how wide it is, so it can accommodate the presence of hematoma without port compression. Subsequently, neurological deficits is not frequently seen with these fractures. Now, the fracture, the extension, sudden extension movement may result in pull-out fracture from the corner of C3 or C4, which is known as the teardrop fracture. It is actually due to the attachment of the anterior longitudinal ligament to the corner of the vertebral body. With a sudden backward movement, this part is being avulsed from its location, so that's an avulsion fracture. Associated with prevertebral soft tissue edema and swelling. You can see a tuck fracture in here. You can see a larger one in here. These are the extension teardrop fractures. Moving to the axial loading results in compression fracture. At the C1 level, it is known as Jefferson fracture. As you load on the vertex, the load is being transmitted through the occipital condyles to the lateral masses of C1, pushing them to laterally, displacing them, and disrupting the anterior and the posterior arch, resulting in fractures. This is often associated with disruption of the transverse ligament that actually stabilizes the odontoid process against the back of the anterior arch of C1. This is why you get displacement of the anterior arch anteriorly. This is classic Jefferson fracture, which is burst fracture of C1 vertebral body. Notice the enlargement or increase in the lateral dental space in here, the malalignment of the lateral aspect of the vertebral of the lateral masses of C1 in relation to the lateral edge of C2. So there is a step deformity in here. They are not well aligned. And the uncoverage between the articular surfaces of lateral masses of C1 and the body of C2. The enlargement of the increase of the distance in here and the malalignment with the step deformity between lateral masses of C1 and the body of C2. When it occurs in the rest of the vertebrae, it results in a compression fracture, fragmentation, loss of the vertical height, increased density, loss of alignment, the gibbous deformity, the loss of the integrity of the intervertebral discs above and below, and the widening of the interspinal spaces. This is associated with retropulsion of bone fragments into the spinal canal, formation of a hematoma, and cord compression. Obviously, the treatment is by corporectomy, removal of the damaged vertebra, and placement of a titanium cage associated with fixation by plates and screws from the vertebra above to the vertebra below. Odontoid fracture is a unique type of fracture. There are 3 types to it. The first type, which is not so common, is basically a chip fracture or an avulsion fracture from the tip of the odontoid process, where the ulnar ligament is attached, connecting it to the skull base. The second type is a fracture through the base of the odontoid process, and this is an unstable fracture due to a small contact between the base of the odontoid and the body of C2. If the fracture extends into the body of C2 or involves the facet joints, it has a larger base and it has a better chance of healing, and this is type 3 odontoid fracture. These are best appreciated on the lateral view of the cervical spine, however, should be evaluated with CT scan. A classic appearance of an odontoid fracture through the base, of the odontoid. This is type 2 fracture. And here it is type 3 fracture going through the body of C2 with disruption of the articulation between the lateral masses of C1 and the body of C2. This concludes the presentation for cervical spine injury. I hope you find this useful. This is by no means a comprehensive coverage of all types of fractures. However, it is more like a quick review, and this subject should be taken very seriously, and extensive reading about the subject and the various appearance of cervical spine injuries on plain radiograph, CT scan, and MRI should be extensively studied, particularly by junior residents who are covering emergency on-calls, as well as by the trauma surgeons and the emergency staff, as missing a cervical spine injury is detrimental to patients' survival and outcome, and could have the catastrophic results among those who survive with missed injuries and result into a long-term neurological deficit. Thank you very much.